England 1312. A woman named Margaret is lying on a wooden table in a stone room beneath a monastery in London. She is 24 years old. She has been brought here by her husband, a wool merchant who told the monks that his wife suffers from hysteria, episodes of weeping, refusal to eat, resistance to his authority in the household. He wants her cured. The man standing over her is not a physician in any sense a modern person would recognize. He is a cleric who has studied texts attributed to ancient Greek authorities, but who has never examined a living woman's body. He does not know what organs she contains. He does not know how they function. He has read that the organ responsible for carrying children is not fixed in place, but moves freely through the body like a living creature. That when it migrates upward toward the throat, it presses on the lungs and produces the condition the texts call hysteria from the Greek word for that organ. His treatment plan follows the established protocol. Force the organ back into its proper position through a combination of foul-smelling substances held beneath the woman's nose to repel a downward and fragrant substances applied to her lower body to attract it. If this method fails, he will proceed to fumigation, inserting a tube and directing the smoke of burning herbs into the most private areas of her body to stimulate the organ into movement. If fumigation fails, manual manipulation through the abdominal wall. If manipulation fails, bleeding. If bleeding fails, purgatives that will force her body to avoid whatever corrupt matter is preventing the organ from settling. Margaret is restrained on the table, not because she is violent, but because the treatments she is about to undergo produce involuntary movement that interferes with the practitioner's work. Leather straps across her arms and legs, tightened by an assistant who performs this task regularly enough that his hands move without hesitation. Margaret is looking at the ceiling. The stone is damp. The room smells of smoke and something acidic that she cannot identify. The man above her is preparing his instruments with the calm efficiency of a person who believes completely in the value of what he is about to do. What was about to happen to Margaret was not malpractice. It was medicine. The standard of care prescribed by the most respected medical authorities in the Western world, practiced for centuries across every country in Europe on women whose bodies were understood through a framework so fundamentally wrong that every treatment it produced caused harm and no treatment it produced provided benefit. The men who administered these treatments were not sadists. They were professionals trained at the finest institutions their civilization maintained, operating from textbooks endorsed by the church and the universities and every authority that medieval society recognized. They believed they were healing. The women on their tables knew otherwise. But the women on the tables were not the ones writing the textbooks. Before I show you what happened to Margaret on that table, before I reveal the full catalog of what medieval medicine did to women's bodies in the name of care, I need to take you back. I need to show you how an entire civilization built a medical system around beliefs about women's bodies that were not merely wrong but designed from their very foundations to classify femaleness itself as a disease requiring treatment. Because what happened in that stone room was not an aberration. It was the logical product of 1,000 years of medical theory that began with a simple premise. Women's bodies were broken. And the men who studied those bodies without ever understanding them appointed themselves to fix what was never broken in the first place. You might assume that medieval medicine was simply primitive, that the physicians of the 12th and 13th centuries were doing their best with limited knowledge, making honest mistakes in an era before microscopes and anatomy textbooks and the scientific method. For men's medicine, that assumption is partially true. Medieval physicians treated broken bones, fevers, and battlefield wounds with methods that were crude, but often grounded in practical observation. They set fractures. They cauterized wounds. They learned through trial and error which herbs reduced fever and which pickuses prevented infection. The medicine was rough, but it was connected, however loosely, to reality. For women, the medicine was connected to something else entirely. It was connected to a set of beliefs about the female body that were not merely inaccurate, but actively hostile. Beliefs that classified women's bodies as defective versions of men's bodies. Beliefs that treated femaleness itself as a medical condition, a chronic disorder of constitution that required constant management by male authorities who understood what women's bodies needed better than the women who inhabited them. The foundation was Galen, a Greek physician of the 2nd century, whose theories about the human body dominated European medical thought for over 1,000 years. Galen's system classified all matter including human bodies according to 4 humors: blood, phlegm, yellow bile and black bile. Health was a balance of these humors. Illness was an imbalance. So far the theory applied equally to men and women. But Galen added a distinction that would shape the suffering of women for a millennium. Men were hot and dry. Women were cold and wet. This was not a neutral classification. In the Hummeral framework, hot and dry meant active, strong, rational, complete. Cold and wet meant passive, weak, emotional, incomplete. The female body was literally defined as an inferior version of the male body, lacking the vital heat that would have made it whole. Every medical treatment designed for women began from this premise. The female body was inherently disordered. Its coldness made it accumulate substances that a man's heat would have burned away. Its wetness made it unstable, prone to fluctuations that produced unpredictable symptoms. Its fundamental incompleteness meant that it required external management to function at even a basic level. The physician who treated a man was correcting a temporary imbalance in an otherwise sound system. The physician who treated a woman was managing a permanent deficiency built into her very nature. If you want to understand the full horror of what this framework produced, the treatments it justified, the suffering it caused, the centuries of damage inflicted on women's bodies by men who called themselves healers, then subscribe to this channel right now. Hit that subscribe button because what I am about to reveal is not ancient history in the comfortable sense. The assumptions that medieval medicine built into its treatment of women persisted for centuries. Some of them persist today in examination rooms and hospitals in the documented disparity between how seriously men's pain and women's pain are taken by modern physicians. The stone room where Margaret lies strapped to a table is not as far away as you think. Stay until the end because the connection between what was done to her and what continues to be done will change how you understand the history of medicine forever. The fundamental problem that shaped everything was this. Men control the medical treatment of women's bodies despite knowing almost nothing about them. And the systems that maintained their ignorance were the same systems that maintained their authority. The medieval church prohibited the dissection of human bodies for most of the period. Exceptions existed, and by the 13th century, some Italian universities have begun performing limited anatomical studies, but these dissections were overwhelmingly performed on male bodies. The female body remained largely unexamined from the inside. The physicians who treated women worked not from observation but from texts. Galen, Hippocrates, Aristotle, men who had written centuries earlier, who had never opened a woman's body to study its structures and whose theories about female anatomy were speculations built on the assumption that women were simply incomplete men. The texts taught that the organs responsible for carrying children were not fixed in place, that they moved through the body independently, like an animal trapped inside a larger animal, migrating upward or downward in response to stimuli that the physician could manipulate. This theory, which originated with Hippocrates and was elaborated by Galen and adopted without question by medieval physicians, was the foundation of women's medicine for over 1,000 years. It was never tested. It was never verified through examination. It was never challenged by observation because the people who might have challenged it, the women who lived inside the bodies being described, were excluded from every institution where medical knowledge was produced and transmitted. Women were barred from universities. They were barred from medical schools. They could not study the texts that described their own bodies. They could not practice medicine legally in most of medieval Europe. The exclusion was enforced by law and by the Church, which viewed female participation in medicine as a violation of the natural order that placed men in authority over women's bodies the same way it placed men in authority over women's souls. A woman who treated another woman's illness was not practicing medicine. She was trespassing on male territory. The penalties ranged from fines to imprisonment to, in later centuries, accusations of witchcraft that could end at the stake. This meant that the people experiencing the conditions were barred from studying or treating them. The only people authorized to treat women's bodies were people who had never inhabited a woman's body, who had never experienced the conditions they were treating, and whose understanding of female anatomy came entirely from texts written by other men who had never examined a female body from the inside. The result was a medical system built on a closed loop of male ignorance, reinforcing male authority. The texts said the female body worked in a certain way. The physicians treated women based on what the text said. When the treatments failed, the failure was attributed to the woman's body rather than to the physician's understanding. The texts were never wrong. The woman's body was always the problem. And since the woman could not challenge the texts, could not study them, could not practice the medicine that was being practiced on her, the loop continued unbroken for 1,000 years. The women who did possess practical knowledge of female health, the midwives and herbalists who had accumulated generations of empirical understanding through direct experience with pregnancy, childbirth, monthly cycles, and the conditions that affected women's bodies were not merely excluded from the medical establishment. They were actively persecuted by it. Their knowledge threatened the authority of men whose knowledge was theoretical rather than practical. Their effectiveness exposed the ineffectiveness of the university-trained physicians. They were competitors, and the male medical establishment had access to a weapon that no female healer could match. The institutional power of the church, which could transform a woman who healed with herbs into a woman who cursed with potions with a single accusation. But that persecution comes later. First the treatments, because the treatments are where the theory meets the body, where abstract ideas about cold and wet and wandering organs become smoke and blood and screaming in a stone room. And they began with the most intimate violation the medical system could devise. The wandering organ theory was the foundation upon which medieval women's medicine was built. Every diagnosis, every treatment, every intervention that a physician performed on a woman's body for over 1,000 years was connected directly or indirectly to the belief that the organ responsible for carrying children moved freely through the body like a creature with its own will. Hippocrates described it first in the 5th century before the Common Era. He wrote that this organ was an animal within an animal capable of independent movement driven by desires that the woman could not control and that the physician must manage on her behalf. When it migrated upward, pressing against the lungs and the throat, it produced breathlessness, fainting, anxiety, irrational behavior, uncontrollable weeping, and the full constellation of symptoms that the Greeks called hysteria. When it migrated downward, it produced heaviness in the lower body, lethargy, difficulty walking, and failure to conceive. When it tilted sideways, it produced pain in the flank that could be mistaken for kidney disease or intestinal disorder. Every symptom a woman could present, from headache to heartbreak, could be attributed to the position of this one organ. The theory was a skeleton key that opened every diagnostic door and that therefore never needed to be questioned. Why does she weep? The organ has moved. Why does she refuse food? The organ has moved. Why does she resist her husband's authority? The organ has moved. The answer was always the same. Only the direction of movement varied. Galen adopted the theory and elaborated it with the confidence of a man who had never encountered a fact that contradicted his assumptions. He added the humoral dimension. The organ moved because it was driven by the accumulation of excess cold and wet humors that the female body could not process. The organ was seeking warmth. It was seeking moisture. It was responding to stimuli in ways that the physician could predict and therefore manipulate. Galen's contribution transformed the wandering organ from a mysterious phenomenon into a manageable condition with a clear treatment protocol. If the organ moved because it was seeking warmth, provide warmth to the location where you wanted it to go. If it moved because it was repelled by certain substances, apply those substances to the location where you did not want it to be. The logic was internally consistent. It was also completely wrong. Medieval physicians inherited both theories without modification. The texts of Hippocrates and Galen were copied and recopied across centuries in monasteries and universities, accumulating commentaries that elaborated the original theories without ever questioning their foundations. Each generation of physicians learned from the previous generation's texts that the organ moved. Each generation treated women based on that belief. Each generation produced results that confirmed the belief because the treatments were painful enough to produce dramatic responses that the physicians interpreted as evidence of the organ's movement. A woman who screamed during fumigation was experiencing the organ's resistance to treatment. A woman who fainted during manipulation was experiencing the organ settling into its proper position. A woman who vomited after ingesting purgatives was experiencing the expulsion of the corrupt humors that had driven the organ out of place. Every response the woman's body produced was interpreted through the lens of the theory. And since the theory could explain everything, it could never be disproven by anything. The theory persisted for over 1,000 years. It was not abandoned because it was proven wrong. It was abandoned because the scientific revolution produced methods of investigation that made it impossible to sustain. When anatomists finally examined the female body through systematic dissection, they discovered that the organ was fixed in place by ligaments and connective tissue. It did not move. It had never moved. The entire edifice of medieval women's medicine, centuries of fumigation and manipulation and bleeding and purging, had been built on a foundation that a single dissection could have disproven. But the dissection had never been performed because the people in charge of medicine had never considered it necessary to check whether their theories matched reality. They already knew they were right. The text told them so. The primary treatment for the wandering organ was fumigation. The logic was straightforward within the theory's framework. If the organ had migrated upward, repel it downward by applying foul smells to the nose and attract it downward by applying pleasant smells to the lower body. If it had migrated downward, reverse the process. The organ, being a creature with preferences, would flee from what disgusted it and move toward what pleased it. The physician was not treating a patient. He was hurting an animal inside a patient, and the tools he used to hurt it were smoke and stench. The foul substances applied to the woman's nose during downward fumigation included burning sulfur, animal dung, burned feathers, burned human hair, and bitumen. These were held beneath her nostrils on a cloth or in a small brazier positioned near her face. The smell was overwhelming. Women gagged, wept, turned their heads, and struggled against the restraints that held them on the table. The physician interpreted these responses as evidence that the treatment was working. The organ was responding to the repellent. It was moving. The more violent the woman's reaction, the more confident the physician became that the organ was in motion. Simultaneously, pleasant substances were applied to her lower body. Myrrh, frankincense, sweet oils, and aromatic resins were burned in a small vessel, and the smoke was directed upward through a tube or funnel position between her legs. The tube was inserted into the most private passage of her body to ensure that the fragrant smoke reached the organ directly. The smoke was hot. The tissue it contacted was the most sensitive in the human body. The burns were immediate. The inflammation that followed was severe. Infection in an era before antiseptic practice was common. The woman experienced what can only be described as a burning from the inside. Smoke and heat applied to internal tissue by a man who believed he was coaxing a living creature back to its proper location. The Troa texts compiled in 12th century Salerno and among the most widely copied medical manuscripts of the medieval period describe fumigation procedures with a specificity that confirms how standardized the practice had become. The texts prescribe different fumigation substances for different conditions, suggesting that physicians maintained a pharmacology of smoke the way modern physicians maintain a pharmacology of drugs. Sulfur for severe upward migration, burned wool for moderate cases, garlic smoke for cases complicated by suspected humoral excess. The variety of prescriptions indicates not occasional use but routine practice. A treatment applied regularly across centuries to enormous numbers of women. The effects of repeated fumigation on the tissue it contacted are not difficult to imagine. Burns that healed into scar tissue. Chronic inflammation that produced constant pain. Infections that without antibiotic treatment spread into the surrounding organs and produced systemic illness that the physician then treated with additional fumigation because the new symptoms were attributed to continued movement of the organ. The treatment created the conditions for its own repetition. Each session of fumigation damaged the body. The damage produced new symptoms. The new symptoms were diagnosed as evidence of ongoing disorder. Additional fumigation was prescribed. The cycle could continue for months or years, each round of treatment compounding the damage from the previous round. each round confirming the physician's belief in the severity of the condition and the necessity of continued intervention. Some women endured fumigation dozens of times across the course of treatment that could span years. The cumulative damage to their bodies was severe enough that medieval medical texts themselves occasionally note that prolonged fumigation produced complications. Though the texts attributed these complications to the stubbornness of the woman's condition rather than to the treatment. The possibility that the smoke was causing harm rather than curing illness did not enter the diagnostic framework because the framework did not permit it. The treatment was correct. The text said so. If the woman was getting worse, the disease was getting worse. The solution was not less treatment but more. When fumigation failed to resolve the woman's symptoms, and it always failed because the theory it was based on was wrong, the physician escalated to manual manipulation. The hands-on phase, the stage where the treatment moved from smoke and smell to direct physical contact with the woman's body, performed by men whose understanding of what lay beneath the skin they were pressing, came entirely from texts that bore no relationship to anatomical reality. The procedure began with external manipulation. The physician pressed on the woman's abdomen with both hands, pushing downward and inward, attempting to feel the organ through the abdominal wall and physically guide it toward the position he believed was correct. He was pressing on the body he had never studied through dissection. He did not know what he was touching. The shapes he felt beneath his hands might be the organ he was seeking, or might be the bladder, the intestines, or any other structure that responded to forceful compression with pain and damage rather than therapeutic movement. The distinction was impossible to make through the abdominal wall. And since the physician was not looking for distinctions, but for confirmation of what he already believed, every shape he felt confirmed his diagnosis, and every movement he produced confirmed his treatment. The force applied was considerable. Medieval texts instruct the practitioner to press firmly and to persist despite the patient's distress, which the texts attributed to the organ's resistance to being repositioned rather than to the obvious cause. A man pushing hard on a woman's internal organs through the wall of her abdomen. Some texts describe the practitioner kneeling on the table beside the patient and using his body weight to increase the downward pressure. The pain this produced was extreme internal bruising. Compression of organs that were not designed to be compressed, potential rupture of structures that the physician did not know existed because the texts had not described them. When external manipulation failed, some physicians escalated to internal manipulation. Fingers or instruments inserted into the woman's most private passage to physically contact and reposition the organ from the inside. The Troa texts describe these techniques with a clinical precision that suggests regular practice rather than rare intervention. The instruments used included smooth wooden rods, metal probes, and the physician's own fingers. None were sterilized because the concept of sterilization did not exist. The tissue being contacted was fragile, sensitive, and vulnerable to tearing, which the instruments regularly produced. The infections that followed internal manipulation were among the most dangerous complications of medieval women's medicine, producing fevers that could kill within days in an era where the connection between infection and unclean instruments was centuries from being understood. The woman on the table experienced this as exactly what it was. A man she may not have chosen to consult, brought in by a husband who wanted her behavior corrected, inserting objects into the most intimate area of her body while she was strapped to a table in a room where her protests were interpreted as symptoms rather than objections. The physician heard a woman whose disordered body was resisting treatment. The woman felt something that no amount of medical language could disguise as care. The manipulation was repeated at intervals prescribed by the texts. Weekly in some protocols, multiple times per week in severe cases. Each session produced fresh damage. Inflammation from the previous session had not healed before the next session began. Scar tissue accumulated. Chronic pain developed and was diagnosed as evidence of the organ's continued instability, requiring continued intervention. The loop that had operated with fumigation operated identically with manipulation. Treatment caused damage. Damage produced symptoms. Symptoms justified more treatment. The woman's body deteriorated while the physician's confidence in his methods remained intact because the framework that guided him could not accommodate the possibility that he was the cause of what he was treating. Bloodletting was the universal treatment of medieval medicine. Every condition in every patient at every stage of illness could be treated by opening a vein and draining blood until the physician determined that sufficient corrupt humor had been removed. For men, bloodletting was painful and weakening, but at least governed by a rough practicality. A soldier with a fever was bled from the arm until the fever broke or until the physician decided enough had been removed. For women, bloodletting operated under a different logic entirely. A logic that transformed a general treatment into a targeted assault on the female body. The humoral framework held that women accumulated toxic blood that their cold constitutions could not metabolize. A man's natural heat burned away excess humors the way a fire burns away impurities. A woman's body lacked that heat. The blood accumulated. It thickened. It corrupted. And it needed to be removed artificially when the body's natural monthly purge was insufficient. This meant that any disruption to a woman's monthly cycle, any irregularity, any absence, any reduction in flow was treated as a medical emergency requiring immediate bloodletting to compensate for what the body was failing to expel on its own. The veins opened for female bloodletting were selected based on the theory of humoral correspondence. The belief that specific veins connected to specific organs and that bleeding from the correct vein would draw corrupt blood from the affected area. For women's conditions, the prescribed veins were at the ankle, the inner thigh, and the saphenous vein at the knee. These locations were chosen because of their perceived proximity to the organs of the lower body that the physicians believed were the source of female illness. The woman was positioned on a table or chair, her legs exposed, and the physician or barber surgeon opened the vein with a lancet and collected the blood in a basin. The quantities removed were extraordinary by modern standards. Texts prescribed bleeding until the woman fainted, interpreting unconsciousness as evidence that sufficient corrupt blood had been drained. A woman who remained conscious had not been bled enough. The treatment continued until the body's response, fainting, pallor, loss of muscle control confirmed that the tipping point had been reached. For a woman who was already weakened by illness, malnutrition, or pregnancy, the blood loss could be fatal. For a woman who was healthy, it produced a weakness that lasted days or weeks, and that was frequently followed by infection at the wound site. But the lancet was not the only tool. Leeches were the preferred instrument for targeted bloodletting, and the locations where they were applied to women reveal the extent to which medieval medicine treated the female body as a landscape to be drained rather than a person to be healed. Medical texts prescribed the application of leeches to the inner thighs, the lower abdomen, and in documented cases to the most intimate and sensitive areas of the woman's body placed internally through the birth canal to draw blood from the organs believed to be most directly affected by humoral imbalance. The leeches were inserted by the physician and left to feed until they detached naturally engorged. The experience for the woman requires no elaboration. The texts describe the procedure as therapeutic. The woman experienced it as something for which therapeutic is not the word that comes to mind. Women who were bled repeatedly, which the texts prescribed for chronic conditions and which physicians administered on schedules as regular as any modern medication regimen, developed the symptoms of chronic blood loss, fatigue, pallor, dizziness, inability to concentrate, weakness so severe that standing for extended periods became impossible. These symptoms were diagnosed as evidence of continued humoral imbalance requiring continued bleeding. The physician saw a woman whose corrupt blood was still accumulating despite treatment. What he was actually seeing was a woman whose physician was slowly draining her to death. The treatment produced the symptoms it claimed to cure, and the symptoms justified the continuation of the treatment that produced them. Let me know in the comments whether you think any of these physicians ever questioned why their patients kept getting worse, because the answer explains everything about how a medical system built on false assumptions can persist for 1,000 years. The system did not need to work. It only needed the people running it to believe it was working. And since the people running it were never the people on the table, belief was easy to maintain. The pharmacological arsenal of medieval women's medicine read like an inventory of poisons. The substances prescribed for women's conditions were not inert remedies that simply failed to help. There were toxic compounds that actively damaged the bodies they were administered to, producing symptoms that the physicians then treated with additional toxic compounds in a cycle of poisoning that could continue until the woman's organs gave out. Mercury was the workhorse prescribed for irregularities of the monthly cycle, for infertility, for skin conditions attributed to humoral imbalance, and for virtually any complaint that the physician could connect, however tenuously, to access cold and wet humors. Mercury was administered orally in liquid form, applied topically as a paste, and in some cases introduced directly into the body through the birth canal as a suppository designed to stimulate the organs into proper function. The effects of mercury on the human body were devastating, and they were cumulative. Tremors, tooth loss, hair loss, kidney failure, neurological damage that produced confusion, paranoia, and hallucinations. A woman treated with mercury over a period of weeks or months developed symptoms that medieval physicians attributed to the progression of her original condition rather than to the treatment. The mercury was making her sick. The sickness was treated with more mercury. The loop tightened with each dose. Lead compounds were prescribed with similar enthusiasm. Applied to the skin for conditions attributed to humoral discoloration, ingested in preparations meant to cool the body's excess heat during fever. Lead poisoning produced abdominal pain, fatigue, cognitive impairment, and reproductive damage that could cause miscarriage in pregnant women who are being treated for conditions unrelated to their pregnancy. The physicians who prescribed lead did not understand its toxicity because the concept of cumulative chemical poisoning was centuries from being articulated. They saw a substance that produced visible effects on the body and interpreted those effects as therapeutic rather than destructive. Arsenic appeared in fertility treatments. Small doses prescribed to stimulate the organs responsible for conception into greater activity. The theory held that arsenic's heating properties could counteract the excessive coldness that the humoral framework identified as the cause of infertility. The doses were small enough that acute poisoning was uncommon. Chronic poisoning from repeated administration was not uncommon at all. A woman taking arsenic preparations over months developed the gradual onset of symptoms: weakness, skin lesions, digestive disturbance that the physician attributed to her worsening condition rather than to the substance he was putting into her body. Heller was the purgative of choice for severe cases. A plant so toxic that modern herbalists handle it with gloves. Medieval physicians prescribed it to induce violent vomiting and evacuation of the bowels, a process they called purging, which was intended to expel the corrupt humors that had accumulated in the woman's cold and wet body. The doses prescribed in medical texts produced effects that went far beyond mere discomfort. Uncontrollable vomiting lasting hours. Diarrhea severe enough to cause dangerous dehydration. Cardiac irregularities caused by the plant's toxic compounds. In cases where the dose was miscalculated or where the woman's body was too weakened by previous treatments to survive the purge, the texts acknowledged that Heller was dangerous. They prescribed it anyway because the theory demanded it. A woman full of corrupt humors needed to be emptied. Hallery emptied her. That the empty might kill her was a risk the physician was willing to take because the risk was not his to bear. Pennyroyal completed the pharmacological assault. An herb prescribed specifically to force the onset of the monthly cycle in women whose cycles had stopped or become irregular. Pennyroyal is toxic to the liver. In the doses medieval text prescribed it produced liver damage that manifested as jaundice, abdominal swelling, and pain that the physicians diagnosed as evidence of continued humoral disorder. Women who survived pennyroyal treatment carried a liver damage that shortened their lives by years or decades. Women who did not survive were recorded in medical texts as cases where the disease proved stronger than the remedy. The possibility that the remedy was the disease did not occur to the men writing the texts because the texts had been written by men who had never been on the table. When smoke and hands and poison failed, the medieval physician reached for the knife. Surgical intervention on women's bodies performed by men with no accurate anatomical knowledge, no effective pain management, and no understanding of infection. The stone room where Margaret lay strapped to the table had a second set of instruments that the physician kept for cases where the earlier treatments had not produced the desired result. Metal tools forged by blacksmiths rather than surgical instrument makers. Blades that were sharpened but not sterilized. Cauterizing irons that were heated in the same fire that had warmed the fumigation pot. The progression from fumigation to manipulation to bleeding to surgery was the pipeline of medieval women's medicine. each stage more invasive than the last. Each stage justified by the failure of the previous stage. Each failure attributed to the severity of the woman's condition rather than to the uselessness of the treatment. Cauterization was the most common surgical intervention applied to women's bodies. The application of heated metal to the most sensitive tissue of the lower body to treat conditions ranging from abnormal bleeding to prolapse to pain that the physician attributed to the wandering organ's stubborn refusal to remain in place. The iron was heated until it glowed. The woman was restrained. The iron was pressed against a tissue so densely packed with nerve endings that the pain it produced was among the most extreme the human body can experience. The woman screamed. The assistants held her down. The physician applied the iron for the duration he believed was necessary, a duration determined by texts rather than by the woman's response. Because the texts had established the protocol and the woman's screaming was classified as a symptom rather than a signal to stop. The burns produced by cauterization were severe. Third-degree burns on tissue that healed slowly under the best conditions and that in medieval conditions without sterile dressings or antibiotic treatment frequently became infected. The infection spread. Fever followed. The fever was treated with bloodletting. The bloodletting weakened the woman further. The weakness slowed healing. The slow healing extended the infection. Each treatment compounded the damage of the treatment before it in a cascade that could continue for weeks until the woman either recovered through the resilience of her own body despite everything that had been done to it or died of complications that the physician recorded as the natural progression of an illness too severe for medicine to overcome. Caesarean procedures on living women were rare but documented. The operation involved cutting through the abdominal wall and into the organ that carried children to remove an infant that could not be delivered naturally. The mortality rate for the mother approached 100% because the surgery was performed without any understanding of how to control bleeding from the incisions, how to prevent infection of the open abdominal cavity, or how to repair the organs that had been cut open. The procedure was performed almost exclusively when the mother was already expected to die, and its primary purpose was not to save her life, but to save the infant's soul through baptism before it died with her. The mother's survival was not the objective. Her body was open to reach the child inside it. She was a container being broken to access the contents. The surgical texts that describe the procedure focus almost entirely on the technique for reaching and extracting the infant. The mother's experience, her pain, her terror, her death receives no more attention than the wooden table she lay on. Perineal repairs after childbirth injuries were performed with the same instruments and the same ignorance. Tearing during delivery was common. The repairs involved cutting away damaged tissue and suturing the wound closed with thread and needle by practitioners who had no knowledge of sterile technique. The sutures introduced infection. The infections produced fever, swelling, and pain that made basic bodily functions an ordeal. Some repairs healed badly enough that the woman was left with permanent damage that affected her ability to walk, to sit, to perform the daily tasks that her household required of her. The injury from childbirth was compounded by the injury from its treatment, and both were classified by the medical system as the natural cost of being female. The body was defective. It broke. The physician did what he could. If the repair caused as much damage as the injury, that was the body's fault, not the physician's. The cruelest intersection of medieval medicine and women's bodies occurred around fertility and pregnancy. The stakes were highest here. A woman who could not conceive faced social consequences that ranged from shame to abandonment to confinement in a religious institution. A woman who was pregnant faced medical interventions that endangered both her life and the life she carried. In both cases, the treatments were governed by the same framework of ignorance that produced fumigation and cauterization applied now to the domain where the consequences of being wrong were most severe. Infertility was always attributed to the woman. The medical texts of the medieval period contain no diagnostic framework for male infertility. The possibility that a man's body might be the reason a couple could not conceive did not exist within the humoral system because the male body was hot and dry and therefore functional by definition. If conception did not occur, the woman's cold and wet constitution was obstructing the process. Her body was blocking what his body was providing. The diagnosis was automatic and the burden of treatment fell entirely on her. The diagnostic tests for female fertility were humiliating and medically worthless. The most widely prescribed test involved inserting a clove of garlic into the woman's most private passage and leaving it overnight. In the morning, the physician checked whether the smell of garlic could be detected on the woman's breath. If it could, the reproductive passage was declared open and the woman was theoretically capable of conception. If it could not, the passage was declared blocked, and the physician proceeded to interventions designed to open it. The test measured nothing. It diagnosed nothing. It subjected a woman to an invasive and degrading procedure that produced a result the physician interpreted through a framework that had no connection to reproductive biology. But the test was prescribed in the most authoritative texts of the era. It was standard practice across Europe for centuries, and it was only the beginning. Women diagnosed as blocked underwent treatments designed to force the passage open. Fumigation with increasingly aggressive substances. Internal manipulation with instruments intended to physically clear whatever the physician believed was obstructing conception. Paratives administered to expel the corrupt humors supposedly responsible for the blockage. Each treatment damaged the tissue it contacted. Each round of damage reduced the woman's actual ability to conceive by scarring and inflaming the very structures that reproduction required to function. The treatments for infertility caused infertility. The physicians never made the connection because the framework did not permit it. Pregnancy management was equally dangerous. Physicians prescribed bloodletting during pregnancy based on the humoral theory that pregnant women accumulated excess blood that needed to be drained to prevent complications. The bleeding weakened women whose bodies were already under the strain of sustaining a pregnancy. It produced the exact complications it was intended to prevent: dizziness, fainting, weakness, vulnerability to illness. Paratives were prescribed to prevent the accumulation of corrupt humors during pregnancy. The violent vomiting and evacuation they produced caused dehydration and nutritional depletion in women who needed both fluids and nourishment more than at any other time in their lives. Some purgatives were toxic enough to end the pregnancy entirely, an outcome the physician attributed to the severity of the woman's humoral disorder rather than to the poison he had put into her body. Childbirth itself was paradoxically safer when physicians stayed away from it. Midwives who managed deliveries through practical experience and accumulated generational knowledge achieved outcomes that were measurably better than those produced by physician intervention. Midwives understood through centuries of observation how the process worked. They knew when to intervene and when to wait. They knew which positions eased delivery. They knew which herbs genuinely helped with pain. When physicians intervened in difficult births, they brought instruments, theories, and a confidence in their own authority that consistently produced worse results. The women least served by medieval medicine were the ones whose conditions most required competent care, and competent care existed. It simply existed in the hands of women the medical establishment was working to destroy. Drop a comment about what it means when the people who actually knew how to help were the ones being silenced, because the next part tells you what happened to them. When the treatments failed, and they always failed because the treatments were based on theories that had no connection to the bodies they were applied to, the physician faced a problem. The woman was not better. She might be worse. The fumigation had not resolved her symptoms. The manipulation had not resolved them. The bleeding had not resolved them. The potions had not resolved them. The physician had applied every tool in his arsenal, and the woman on the table was still weeping, still refusing food, still displaying the behaviors that her husband had brought her here to have corrected. The physician needed an explanation that preserved the authority of his methods while accounting for their failure. He found it in the same institution that had authorized his practice in the first place, the church. The transition was seamless. A woman whose condition resisted medical treatment was reclassified. Her disorder was no longer physical. It was spiritual. The wandering organ had been replaced by a wandering demon. The language shifted. The diagnosis shifted. The authority over the woman's body shifted from the physician to the clergy. But the woman's experience did not shift. She remained on the table. The straps remained tight. The only thing that changed was the explanation for why she was there. Spiritual diagnosis opened a new category of treatment. Exorcism, confinement, penance, prayer administered not as comfort but as prescription recited over the woman's body while she was restrained, repeated for hours or days until the spiritual affliction was considered expelled. The exorcism rituals varied by region and by the religious order conducting them, but the physical components were consistent. The woman was held down. Holy water was poured over her. Prayers were shouted at a volume intended to drive the demon from her body through sheer spiritual force. In some documented cases, the woman was struck during exorcism. The blows intended not to punish her, but to make her body an inhospitable environment for the entity that inhabited it. The logic was identical to fumigation. Apply something unpleasant to drive the unwanted occupant out. The smoke had been replaced by scripture. The result for the woman was the same. Confinement followed when exorcism failed. Women whose symptoms persisted after both medical and spiritual treatment were placed in religious institutions, convents, monasteries with attached women's quarters, or dedicated houses of confinement maintained by religious orders. The duration of confinement was indeterminate. Some women were held for weeks, some for months, some for the remainder of their lives. The conditions varied enormously. Well-funded institutions maintained by wealthy orders provided austere but survivable conditions, plain food, prayer schedules, manual labor, and limited contact with the outside world. Poorly maintained institutions provided something closer to imprisonment. Women chained to walls or to beds to prevent them from harming themselves or others. A precaution that the keepers applied liberally to women whose spiritual affliction manifested as resistance to confinement. Women starved as part of purification rituals designed to weaken the body so that the spirit could be more easily cleansed. Women immersed in cold water, the shock intended to drive out the demonic presence the way a sudden noise drives out a rat. The woman who had entered the medical system with symptoms that a modern physician would recognize as depression, anxiety, grief, or the natural response of a human being to a life she had not chosen and could not escape emerged from the institutional system broken. The original symptoms, the weeping and the refusal to eat and the resistance that her husband had found intolerable had been buried beneath layers of medical injury, spiritual trauma, and the psychological damage of months or years spent confined in a stone room being told that the pain she felt was evidence of evil inside her. The system had not treated her illness. It had treated her identity. It had taken a woman who was suffering and classified her suffering as defect, first physical and then spiritual. And it had applied treatments designed not to alleviate the suffering, but to eliminate the woman who expressed it. What emerged from the confinement was not a healed person. It was a silenced one. And silence was the only outcome the system had ever been designed to produce. The women who actually knew how to help other women were the ones the system destroyed most thoroughly. Midwives, herbalists, village healers, women who had accumulated generations of practical knowledge about the female body through direct experience passed from mother to daughter across centuries. They understood pregnancy because they had witnessed hundreds of births. They understood monthly cycles because they had experienced them. They understood which herbs eased pain, which plants reduced fever, which preparations helped a woman through the most dangerous hours of her life. Their knowledge was empirical. It was observational. It was in many cases more effective than anything the university-trained physicians offered because it was built on watching what actually happened to actual bodies rather than on reading what a Greek philosopher had speculated 1,000 years earlier. The male medical establishment viewed these women as a threat. Not because their methods were dangerous, but because their methods worked. A midwife who successfully managed a difficult birth exposed the inadequacy of the physician who would have reached for instruments and theories and produced a worse outcome. A herbalist who relieved pain with willow bark and chamomile undermined the authority of a physician whose pharmacology consisted of mercury and whore. The female healers were competitors operating outside the institutional framework that gave male physicians their authority. And the institutional framework had a mechanism for eliminating competition that no herbalist or midwife could defend against. The church provided the weapon. Female healing had always existed in an uneasy relationship with church doctrine. A woman who used herbs to treat illness operated in a space that theology could classify as either medicine or sorcery depending on the intentions of the person making the classification. The same preparation of plants that one observer called a remedy, Another observer could call a potion. The same hands that one community trusted to deliver a baby, another authority could accuse of using dark arts. The boundary between healing and witchcraft was not defined by what the woman did. It was defined by who was describing what she did. And by the 15th century, the people doing the describing had decided that female healing was demonic. The Malleus Maleficarum, published in 1487 by the Dominican friar Heinrich Kramer, made the connection explicit. The text, which became the most influential handbook on witchcraft in European history, specifically identified midwives as among the most dangerous practitioners of dark arts. Women who assisted in childbirth were accused of secretly harming infants. Women who used herbs were accused of brewing poisons and curses. Women who possessed knowledge of the female body that male physicians did not possess were accused of having obtained that knowledge through communion with demonic forces, because no natural explanation could account for a woman knowing more than a man trained at a university.